And you start paying in young and you use the services and you don't have to worry because it's a system that's based on that. I know today there is income testing for premiums as well. I talked to my two nephews and they are currently college students. They're on their parents' insurance, but when they earn over a certain limit, they also have to pay premiums. So it's not free completely. If they have part-time jobs, the health insurance is income tested and they have to pay some premiums. There's co-pays, and similar to America, their healthcare is delivered federally and locally. Germany has states, it's big enough to, it's a federal system, and most of the healthcare delivery is local, but there is also a national system. And really the big role of the general practitioner, that's one of the things I just don't understand in the United States, how specialists are so much more important than general practitioners. I know where I go for my annual checkup, they don't like me because I come once a year. I don't want any referrals because I don't see a reason for that, if I don't have any specific things. And I'm sort of a loss maker for them because I just want a proper checkup. And that's not how I've experienced the healthcare system in Germany and in New Zealand. That annual checkup is part of the long-term financial strategy of prevention. Prevention is big. And it's also in the private system. My dad worked for IBM for many years, had private health insurance, and they insisted on an annual checkup. The company even paid for some of that. So he would have his annual checkup because they wanted him to stay healthy, get his tests early so that if there was anything coming on, people could take care of it at the least cost. So private insurance was the same in many ways too, because they promoted prevention over just a lot of services.
Bettina, I want to check with the online audience to see how you're hearing. How are you hearing, Bettina? Good? No, negative? Thumbs up, thumbs down. How about volume? Can you hear her? Can you hear Bettina okay? Thumbs up? Okay.
Yeah, very good.
What did she say? Sorry, Bettina.
So probably the most serious health concern that I was aware of when I was growing up in Germany was my mom's health concern. She had a pancreas condition that, would flare up pretty badly, where she would be so sick that one Christmas Eve she was admitted to a hospital because it was so serious. But all I knew is what her general practitioner was in charge of that service and what would be done. And he would make sure that she would have the least service, but when it got serious and he couldn't do anything with the drugs that she was getting and she wasn't stable enough, then she would be admitted to hospital. But mostly it was all what he could do, he would do. And he would potentially consult with others, but she wouldn't be sent to A, B, C, D. He would just do most of it. And that's worked for her for her whole life. And I know that it's not been an easy condition, but I know that with whatever he did, it was stabilized. And, she's now 83. So it's a long time that she's lived with that condition. So moving to the New Zealand system, which to me felt very similar to the German system, as you can see, because it's also a public healthcare system with the option of private insurance. And at that time I was working. Public health insurance is, again, you go to a general practitioner, you sign up to a doctor, and most of referrals come from there. It's not income tested. It comes right out of taxes. And it covers a lot of the regular tests and lab work. I remember when my American husband, moved to New Zealand and he was there for 5 summers in a row, he would have his annual checkups and he was surprised that the labs were paid for by the public system. There was no co-pays. They were quickly tested. And after his general visit, when the lab results came back, the GP would call our home and talk the results through with him because he had hereditary blood pressure and cholesterol, medications that he was taking. But we would get that phone call at 7 at night from the GP, and he would just talk because he knew it was a pharmacist. They'd be talking things through, and he. Um, and at that time, we were both permanent residents in New Zealand. There was private insurance, and I chose private insurance as an additional option because that would help get me potentially to tests quicker, that would allow me to just shortcut some services that in the public system might take more time. But the premium for both of us was $150 a month. For two adults who were at the time in their 40s and their 50s, we paid $150 a month to have private health insurance, to access private health care if we needed it. The other part of that was that if I didn't need it, I wouldn't claim till the end of the year, and then I would get premium back. And if I didn't have many costs, my premium would go down the next year. So this was always like with an HSA, where you think, do you pay this privately or do you claim it? I would, at the end of the year, I'd said I had enough money not to have to worry about right away, but I would collect my bills, and at the end of the year, I'd think, what's better, claiming or getting a reduction on my premium for the next year? And I got reductions of my premiums several years in a row because I was healthy. So I didn't need to use my private insurance because all my healthcare needs were covered by my public insurance, which I pay taxes for. New Zealand has co-pays. Probably the highest co-pays I experienced was in dental care. There might have been $70 at the time, and $30 on a general GP visit. No lab costs. There was no co-pays for the regular labs. But, you probably all read about waiting lists for non-urgent care. So there are waiting lists. I didn't need a hernia, or I didn't need any of the non-urgent surgery, but I know that there's waiting lists, and there's probably statistics about that. But what I know, that I had two friends who experienced cancer, and they got first-rate treatment. I would consider what they got first-rate treatment in the medical system, in the hospital, with the nurses that would come to the home and help with pain care. Everything that they needed for the cancer treatment, they received. And two of my good friends, they got through treatment and survived, and one of them had to go through hospice care, and he passed away. But through that, his wife and his family were supported all around, and they wrapped the services around, and he got the best, and it was all public. It was all public health insurance. The personal experience I have was with public accident insurance. New Zealand has a public accident insurance, and it's for personal injury. So it covers personal injury from an accident, self-inflicted or not. Mine was by a dog who bit me in my face, my own dog. And the accident insurance pays for the treatment that you need after an accident, which also means that car insurance premiums are low because all injuries from car accidents are removed from the car insurance. It's part of the public insurance. There is no dog insurance for accidents. There's just dog insurance for bringing down fences or, doing other stuff that dogs do or animals do. But what I received, I had my dog bite me, and it was a bull mastiff, so it's a big dog. I got treatment in the emergency room, and then I got plastic surgery to remove the scar tissue about 6 months later. And that was all covered by the public accident insurance. And public accident insurance is like the Oregon Saves. It's a little premium that you pay in addition to your taxes. So it was a little bit of money that we had to pay annually without taxes. We got deducted accident insurance premiums. And I worked for the accident insurance company for a while doing some financial analysis, and it's just like a huge bank. It's like any health insurance. They have a lot of money that they manage, One of the other parts of New Zealand accident insurance is that it's a no fault. So there's very legal costs, really only severe negligence you can actually sue for. Everything else, there is fixed costs for, loss of limb and part of loss of limb. It's all in policy manuals. So there's no real question. But I experience it as something that, because it's no fault, even me, not being able to manage my dog, I was looked after, and that accident really didn't cost me anything. But it also covers work accidents. And again, the accident insurance does a lot of prevention, like Bowley here for workers' comp, does a lot of education, works closely with employers to make sure people don't have accidents. But when there is an accident, you don't have to worry if the other car driver's insured, you don't have to worry about, that liability piece. So that's really the New Zealand health insurance system. So my reflection is really that public systems work. I don't know why. And I think they work because I grew up in a social democracy, so that health is not something that we get like education. It's just not in my experience. So it's hard for me to know that health is sort of below education in terms of what our taxes pay for. And I think that big pool makes a big difference. One of the things that happens in the German system, if you opt out and then something happens, like, young people often have accidents or the unexpected things, they can't just jump back in and think they can get their services. That's what I tell my younger staff too. Public systems are about sharing the experience rating. We currently actually trying to lobby that all nonprofits go on the Oregon Health Plan, because that would be a great way of helping nonprofits, be that pool of younger employees and older. I've just looked at my census as we're trying to get some, just a life policy for the Old Mill Center staff. But wouldn't it be great if all nonprofit employees could be on the Oregon Health Plan to create a great pool and potentially help with overall rates as well? It's been talked about, but it hasn't been lobbied. But we're talking to the Nonprofit Association of Oregon to potentially put it on the legislative agenda, because I think it would really be helpful. But that's the big piece of universal healthcare, is that everyone pays, everyone gets services, and having a pool is what makes it affordable for the population, and doesn't mean that we make ourselves not think that the write-offs at the emergency room that happen for people who are uninsured are not part of the taxes we pay. It's just not transparent. The other part is prevention. I think prevention is really at the base of all public health systems, because whatever, it's like with Social Security, whatever people pay in has to last to pay for everyone. And that incentivizes prevention. It incentivizes early eye checks, early dental checks, early blood pressure checks. It incentivizes education about weight management, about checking out things that might need like an occupational therapist rather than letting it go worse. And prevention, I think, is part of the long-term financial strategy for any insurance. And that's why it's so hard to think that we don't do enough of that. Yeah, I think that's really all I could say. I'm not the financial buzz. I've never worked in health industry other than now, but I've experienced it, and I struggle. I struggled when my husband was denied health insurance when we came back from New Zealand, and I got health insurance and he didn't get it because he had pre-existing conditions. It was sort of, oh, we're going to go back. After he was denied 3 times. And then he was an Oregonian. They had health history on him. He is healthy, and he couldn't get health insurance, which to me made no sense. But it explained to me why health insurance, private health insurance here, is not for health, it's for profit. And so I'm very jaded. I can't really, but I have seen public and private health insurance work together. I think there is a place for it for people to get in faster. I knew because my dad had private health insurance on top of public that we sometimes got appointments faster. But in New Zealand, it was really for me, it was, yeah, if we needed it, we had an option. But the health insurance companies had to make it work too by having the right census.
I think this will work.
Okay. Let's see, can you folks on screen hear me?
Here's the mic.
Yeah. Oh, okay, great. So you mentioned about there are some wait times. And in my adult life, I think I've only had 2 surgeries here in the US. And both times there was a curious wait time. I tore a muscle right off my arm. It took 6 weeks to get into surgery. This spring, my gallbladder died before the rest of me. And I lay in a hospital bed, unable to eat, unable to think because of the pain and such for 3 days before I could get in. 3 days doesn't sound like a lot, but when you are, the only thing you can take in is fluid and Oxycontin, that there's a certain amount of danger there. What kinds of wait times can you recall, or have you heard? What are we talking about? Is it really that different between what everybody I know who has a surgery waits in the United States?
I think some of some of the what they consider non-urgent, which could be hernias or hip surgery, it could be months to get scheduled.
Uh-huh.
And I know some people would go to Australia to have their surgery, but there is capacity. I think there is capacity in the system. It just gets prioritized towards the sicker people.
Sure.
When needed. And that's, I think, when you wait too, it gets prioritized towards the sicker people, hopefully.
Yeah. Thank
But
you.
then I wasn't aware, all these different charges for the same service, that we have is also very curious to me that there's so many, you could pay $5 and you could pay $100 for the same service. And that is so peculiar to me from if charges are based on cost.
Yeah. Do we have any questions from the folks online? Anybody want to ask anything?
I have a question about the 12% in Germany who subscribe to private. Do you have any words of wisdom about why they did that?
I imagine that the premiums are lower for private insurance if based on because it's all about how old you are, what pre-existing conditions you have. So I imagine those premiums for a 25-year-old are cheaper than what you pay for the public insurance, because public insurance does it on your lifetime and you start paying, what it might cost for your lifetime. So I started with $400 a month when I was 25, taken out of my pay for health insurance. And when you are here, when you get insured and you're 25, you can probably get a insurance for $50 or $60 a month. So people would go for the cheap one because they were young. But then, reading the small print as well on what do you get. They probably assume you're healthy and then everything's excluded.
I see. Thank you.
Other questions? Yes.
Yeah, I have a question. Well, actually 2 questions now, since in response to your last response. So you mentioned in Germany, that you have those premiums, and you just said those premiums will be based on, age and pre-existing conditions and all that. Was New Zealand How did that compare to New Zealand as far as what you paid in? I'm wondering, and did that also change based on like, was that progressive based on your earning or change versus age? Can you comment on that?
The private insurance was based on age and gender mainly for the premiums. The public system didn't, it was just part of taxes. So there was nothing that we specifically paid for health insurance. We just pay taxes. And like, I'm really happy when I go to the library here because we pay, property taxes and I'm getting back. I was always thinking, oh, when I go to lab test, I'm just getting part of my taxes back as a benefit. So that's how I thought about my taxes that I got out of my pay. But we didn't pay a specific premium for health insurance. It was just part of the annual taxes that we paid. But my private health insurance was 156 a month. So that would have been about 70 a person a month for the private health insurance, in addition to potentially get additional services.
So when you paid taxes, there wasn't a separate category saying your health tax is this. You didn't even see how much of it went towards healthcare, you're saying?
No, the only thing I saw was my accident insurance premium, which was separate. And there was a very small amount.
Okay, thank you.
So did people have any complaints about this, either in Germany or New Zealand, about those systems? They seem pretty wonderful to us.
I think the wait times is what I heard the most. And I didn't hear any complaints about, the drugs aren't available or, any of those complaints. I can't get what I want. The referrals, you like here too, at times where you need a referral from a general practitioner or your doctor to get additional services. So sometimes people didn't want that, but because the GP visit was a $25, $30 copay, and some of that was income-based too, the copays would go down if you were on lower income, then that visit wasn't expensive. I don't have an experience of people saying they were unhappy with it at all.
Yeah, it sounds great.
Definitely the private hospitals were fancier than the public hospitals. No, I lived in Wellington and Auckland Hospital was just an old hospital in many ways, with narrow corridors, and it's when they build new things, they build them more up. But definitely the private hospitals were newer, were a little bit fancier with a little bit bigger rooms. And I think that's the same in Germany. When you're on private insurance, you would get a single room rather than put in a 2 or 3, so you don't have those choices at times when you are on the public system. So your private insurance gets you, they bump up. That's part of my private insurance, was that I could have potentially had a single room, wouldn't have to share, or double rather than a full or something.
Let's see, Bobby has a question and Mike has, but let's go to Bobby.
He's muted, I think.
Okay, can everybody hear me now? I hope so. All right. I just wanted to say, you wrote a blog with me, and I talked about my 4 years in Canada. And in Canada, everything was covered for medical, but it didn't include dentistry or vision. But anything you could do in a hospital was covered. And it was very, very simple and very complete at that time. I don't know if it's as complete now. But I just wanted to mention that the single payer plan that the Oregon Task Force for Universal Healthcare has now completed, and it's going to be finalized this very Thursday and sent to the legislature. It covers everything, and it saves money. Saves $1 billion, $1 billion that would otherwise have to be paid in 2026. It just makes you want to weep. I don't know how long it will be available, but it's for all residents, irrespective of immigration status, irrespective of age, employment, and so on and so forth. So it's a wonderful idea, and it's been worked out very well. And I think you'll like it. I hope so. I think everyone will like it. Everyone who has looked at it carefully likes it. And it does, it will cost, employers will have to pay something, but not what they're doing now, not that much. And it will cost people who make more than 200% of the federal poverty level. They will have to pay something in their income tax. But, you know, as I wrote when I wrote my blog about Canada, when I got there, I found I had to pay tax on a car that we bought a month or two before we moved to Canada. We only did it because the car that we had was a Saab, and at that time in 1970, they didn't have service for Saabs, and I didn't want to be in a position of having a car out of commission because of a foolish accident such as I had once with the car in Oregon. So I thought, oh gosh, I got to pay sales tax on it. But I did, and I stayed there for 4 years. I used the emergency hospital once when we were camping, and I needed to go to the hospital. Just walked in and I was taken care of. That was it. They said, how long have you lived here? I said, 2 years. Oh, okay, fine. Anyway, so I think that the systems you talked about are wonderful, and it's very, very fascinating how every country has developed their own way. I have a friend who lives in New Zealand now. She was a student here in Oregon, but she married a guy in New Zealand and did historic archaeology. And the way she explained it was very difficult, and how you explained it was more clear, much more clear. But I think it's fascinating how every country has figured out a different way to handle this this system, and probably if Oregon gets our system, it'll probably change in a few years, and I think that's okay. Anyway, thank you very much.
I just read too that New Zealand actually changed from a regional system to a national system recently, because they thought that sort of like the zip code determined services you got, and that wasn't seen as adequate. So in 2021, there's now a more national approach.
Oh.
Billion, you know, you can do that, because I used to work. I worked for the ambulance service over there too, the St. John ambulance service, and it was regional hospitals. But it appears that maybe because of the more rural and more urban, that there was disparities in access, and that's been removed by making it more national again. So it's not static. You know, there is things that don't work. Sometimes you have to do this redistribution so that access is equitable again.
Right.
Mike.
How about drug prices, just from your own going to the pharmacy versus the cost to the government? We know that New Zealand is the only other country that allows advertising of prescription drugs. Do you know if the medical industrial complex really affects New Zealand that much in terms of pricing of drugs?
I don't know. I'm married to a legal drug dealer, but I don't take any drugs. So but I think when Jeff got his regular drugs, he would have a copay, and it was for a 6-month supply, and it was very limited. Like his regular blood pressure and cholesterol medication was $3 for every 6 months or something. And at times it was you had to get it every 3 months, and then it was every 6 months they got 2. But it was just a minimal amount, and there were the regular. New Zealand has, like here too, has a system of what drugs are supported by the public health system and what is not part of the regular. You have to, sort of negotiate or have the need to have a special drug. But yes, sadly, New Zealand is one of the countries where drug advertising is on TV. Sad, but I don't think it affects the country. Still negotiates globally for the drug prices as well.
What are you all thinking about Measure 111?
Who wants to start on that?
Well, our board voted, and in the end, it was a unanimous vote to support Measure 111. Oh, our board voted unanimously to support Measure 111. It is controversial, and it is, I mean, there are issues there, I think, that we all see, but the worry is that if we vote no on, that if Oregon votes no on Measure 111, the legislature will possibly take that as a sign that we don't actually want universal health care, and the plan that Bobby is so enthused about may simply be put on the shelf. Because what has to happen is the legislature has to act on that plan. Just because they've funded it and they had people create it for them doesn't mean they're going to adopt it. And if Measure 111 fails,
But if it passes, then what?
then they have to create a plan, and hopefully they pick the plan they've already had created. But there's no guarantee there. We would have to work hard to keep them on track, I think.
So would we vote again on the plan?
I think that could happen, yes. I think they could simply adopt the plan, though, couldn't they?
It'll be challenged, so it depends on the voters. Whether it passes or not, it'll be challenged, and it'll come to the voters as a ballot measure.
Okay.
It is going to be ballot measure, isn't it?
Well, first the legislature would vote on it. If they vote it down, we'd have to start an initiative.
I thought 111 is a ballot measure.
It is.
Oh,
I think there's a little confusion here. We are going to vote on ballot measure 111, but what Mike's saying is then there would likely be another vote later. Because it would.
Specific plan.
Yeah.
They're not connected. They're not connected.
Yeah, 111 is a constitutional amendment only. And there's a separate decision track for the legislature on the task force report. And what will be asked for in the session is to establish the governing board who will actually create a plan that the legislature would then vote on. So there's a few more steps along the road before we get there.
Very serious steps. Were there any more questions from folks on screen? I see Alex.
Yeah, I don't know if Bettina can answer this question, but I'm going to ask it anyway. I know you work at Old Mill, and so children and adolescents are your clientele. I'm just curious. I mean, we have kind of a crisis in this country, serving children and adolescents as far as mental health go, behavioral health. So I'm just wondering, I don't know if you were involved in that at all in either countries that you were in before, but I was just curious, like here, we don't have enough providers, we don't have inpatient beds, even outpatient services are limited. Do you know, does Germany or New Zealand, is there any kind of similar crisis going on there, or does their public health system take care of that as well?
I really can't speak to it in terms of what Germany and New Zealand are doing. I just wasn't close enough to the mental health system. My perspective on what's happening here is if we don't start looking at prevention, we will have 99% of the population mental health services. We need to step back and really address some of the reasons. You know, yes, at Old Mill, we deal with trauma and some pretty serious mental health issues, but a lot of what coming up with the pandemic is also lifestyle. It's just put the social media and all these unhealthy lifestyle things that we all do, it's augmented those. And now we don't know how to get out of it. We struggle to get mental health clinicians. It's a real problem, but I'm thinking the solution is not to double or triple the mental health counselor population, but it's actually looking at what we can do to make people more resilient and healthy and get rid of the many, many unhealthy lifestyle choices that we make today that are creating this crisis. That's just my personal, yes, I can put more clinicians, and we're trying to get more clinicians, and we actually educate a lot at Old Mill. We have a lot of interns, which is part of creating the future pipeline, which we do because we can't afford any licensed clinicians under the Medicaid rates. But really my overall thing is we need to just find ways of living healthier so our mental health is not so compromised. I just think we're looking at the wrong thing by throwing more and more clinicians out there. It's
Thank you.
my personal perspective.
Other questions? Not seeing a lot of hands. I wondered if you would say, I mean, obviously right now we are very much focused on this task force plan and trying to bring it into reality. But there will come a time when we may have time to deal with some other things. And you mentioned this notion of putting all private nonprofits on the Oregon Health Plan. Could you say just a little more about that? That might be something down the road that we could help support, it seems to me.
As an employer, we have 69 staff. Health insurance is one of the only benefits we can afford, but it's also a benefit that's expensive. And I'm just waiting for the increases to come. They're probably going to be between 6.5% and 9%. And for retention, we will have to find ways of paying for those because our staff can choose to go to the county and to the school district to get more benefits. And that's really what nonprofits already pay less. And then we struggle with benefits. And some smaller nonprofits don't give any health insurance benefits. They might give a stipend to go towards benefits. And it should not be that employees and nonprofits have less access to those services because they work as hard as anyone else. So when we know that nonprofits are one of the larger employers, probably 12, 14, 15%. If we count hospitals who are not really nonprofits, we have even more. There is a huge workforce, and it also is a relatively young workforce. At Old Mill, we employ a lot of graduates, teachers, early interventionists, counselors that are coming right out of college. And yes, they might not need as much health insurance, but it's still a benefit. And some of them have health conditions that they should be insured for. And a health savings account might not be the best thing. So why not create for the Oregon Health Plan a good, solid group of people? When we first came, I said my husband was declined in health insurance. So he was in what was then OMIP, the medical pool, Oregon medical pool. That's the only way we could insure him. And it seemed like a catastrophic health insurance. But he was probably the cheapest because he cost them $2,000 when the average was $1 million. Because in OMID before Obamacare, we had only the sickest people. And if we put more people in, Oregon Health Plan can actually do more. How can Oregon Health Plan can spend more money on prevention, can use the waiver that we have to do even better stuff to prevent. Because that's what holds us back, is having enough money to do more serious prevention. So it's a great pool. I think it's a pool that deserves health insurance. It's really hard to look at, the county whose taxes we pay, who can offer family insurance, and my staff go there. And they go there because they can save $16,000 a year. Why? I'm just like, why do I pay property taxes for that and I can't offer it to my staff, who deserve exactly the same thing? So
That makes a lot of sense.
that's my logic. And the second one that I would like to put on the agenda, if I had a future thing, is to get rid of the 9% that gets charged if your medical debt goes to debt collection. I'm a trained mediator, and when I came to America, I trained as a mediator. I mediated in small claims court, and half of the claims are medical debt. And because Oregon statute charges 9% on debt, that's a debt on poverty. That's an interest on poverty.
Wow.
And that should not be in statute. I personally paid off some medical debt for poor people and gave them a 0% loan, because it's just completely discrimination for poor people. And there was very little we could do once it was in debt collection. The advice I give everyone who has medical debt, just pay $25, and you don't get it into collections. But once it's in collections, there's nothing you can negotiate because it's by statute. And the statute is 9%. And so I'd like that change if I had a vote. And it's a little thing, but it is so discriminative against poor people. 9% makes, $25 very big in a year or two. And all you're paying is the interest.
I've heard that in some parts of our country, debt from medical expenses will no longer,
For your credit score.
yeah,
Here too.
is that true? here
But
also?
still, you have to pay.
Oh,
It still adds up. It's up, and it's a debt. And it just doesn't go against the credit score, but it doesn't.
oh, okay, it doesn't count against your credit score. Oh,
That's
okay.
the only change.
Oh,
Okay.
So hard.
I'll bet. Unless there is one last question, we are starting to run a little long time-wise, and we have a couple of other things to do, including one thing to vote on. But is there any last question or comment?
Thank you very much.
Yes, thank you. Right.